Call the March 11th, 2022 Board of Health, yes, right, to order. And I don't believe we have anyone, do we have anyone on electronically? So this is the board makeup today? Okay,
That's it.
Great. All right, Chris, are there any adjustments that we need to make to the agenda?
No, we just need to approve the minutes from the last meeting, and then
Okay.
I'm gonna go over a electronic participation policy with everyone before Monica gives her
So
presentation.
let's go ahead and take item 1, which is a approval of the meeting minutes. Is there a motion? Motion. Motion by Chief. Is there a second? Second. All those in favor, please say aye.
Aye.
Motion carries. The next agenda item that we have is actually something that we've had to do with all of our boards recently per the governor's order. So I'll have Chris just kind of explain this, and then we'll entertain the motion.
Thanks. So, as the mayor mentioned, we've taken this policy to all of our city boards and commissions. This is an electronic participation policy. So Indiana's open door law has requirements with respect to how we meet, right, in public settings. And during the pandemic, there were some state executive orders that were issued that greatly loosened those rules and regulations and allowed us to communicate via electronic participation, Teams calls, et cetera. The outcome of that was that last year the General Assembly adopted new legislation that gave public bodies from cities the opportunity to have electronic participation where we didn't have that right before, according with certain principles that are outlined in the policy. So the upshot for you all is that you have the ability to participate through an electronic participation, electronic means, if necessary, for a certain number of meetings throughout the course of the year. And then if we were to ever go back into some sort of an emergency state, which hopefully we don't, but if we were ever to go back to that, then these rules and regulations would allow us to meet all virtually. So we have that flexibility for public bodies. But without this policy that's before you, without adopting it, we don't have the ability to meet other than present in person. So if you have any questions with that, I'd be happy to answer them.
Any questions, Chief?
Yeah, the governor's equivalent, there cannot.
It could be both. So there's, that's a good question. So the chief asked about the emergency declaration. So going back to the early dark days of the pandemic, there were two kind of triggers for these emergency regulations. One was a local declaration that was issued by the mayor. The other was the statewide emergency issued by the governor. Either of those two triggers would allow us to all meet virtually if we ever had to again. But otherwise, we'll abide by the general parameters of the policy.
Any additional questions? Seeing none, is there a motion? Motion, is there a second?
Second.
Second, all those in favor, please say aye.
Aye.
Motion carries. I would ask, I talked to Chris about this earlier, as we transition out of kind of the higher stress, higher profile aspects of COVID and the response to the pandemic, we get more into the collaborative side of where are we going next, how are we going to continue to progress this kind of culture of health here in our city. This format seems a bit formal for our ability to just talk through different ideas and things like that. So ideally, I'd like to move venues, maybe to an administrative conference room or pavilion. If we had a situation, Monica, where something came up that we had to, I don't know, take a formal vote on something or consider a complaint from a resident or whatever, I'm fine coming back down here. But it would seem more conducive for us to actually, I don't know, brainstorm and talk through things, not when you're standing at a podium presenting. That's my thought. I don't know, I haven't run that over by any of you guys, but are you guys fine with that? Okay. I mean, we do have a big audience, Carrie's here, so. Yeah. It would still, to be clear, it would still be a public meeting. It would still be advertised. People could still attend if they so chose, and we would make accommodations for it. But I would rather have us have more working meetings rather than the formality of this venue. And on that note, for the formal presentation, Monica, you want to give us an update? Josh, haven't seen you in a while. I do miss our arguments.
Debates?
Yeah.
Oh, we don't have a little door. Okay, well, I will get started. Monica will take over halfway through, but.
Will you make sure the microphone's on?
Hi.
There you go.
There we go. Thank you. Welcome back. It's been a long time, and I'm realizing here's the keyboard. So what I'll run through is a pseudo quick recap of COVID as it stands leading into the CDC's changes to community level guidance, and try my best to recall everything from memory, but I have a lot of notes here, so this will be fun. As I mentioned, go over vaccines cases, CDC guidance, service transition. I'll touch a bit on the annual report, which is really exciting and can't wait for that to come out. And then Monica will take over to talk more about population health, community health assessment, updates, and finances. So in front of you, two screenshots or two images. One is a screenshot of our vaccination dashboard, which I now manually update once every 2 weeks. It has millions of data points that go into it. It literally takes a separate machine all day to do it. But the numbers aren't very far off. We've been increasing incrementally in terms of coverage for the last 5 to 6 weeks because uptake is waning a bit and we have high coverage. But overall, our vaccination coverage is quite extraordinary. We have about 92% of 18 and older adults that are fully have received their first dose. And the 5 to 17 is the bottom number on the left hand, the 74.2%. That's another really encouraging number. When I break it out by the 5 to 11%, we have around 53% of 5 to 11-year-olds, and the statewide average is 19.5%. So it's really encouraging to see that high uptake that we've had throughout the pandemic and when those services were offered. What isn't on here, but what I do calculate on my own is booster uptake. That again takes a while to do, so I do it near the end of each month. And at the end of February, our booster uptake for 12 plus population, so 12 and older, was 60% compared to 43% for Indiana and 44% for the US. When you look at it at 18 and older, booster uptake here in Fishers was 62%, and that was 15% higher than the general US population. And when you look at it at 65 and older, ours is 80%. The US general population at that time was 66%. And then moving on to cases, on the right are cases all time by 7-day periods. And what I flagged up there in the different colors are the variant waves that we saw in 2021. And I sort of highlight right when they start and cover where they start to decline. And in terms of total cases, we've had about 25,062 in Fishers that have been reported all time. In 2021, those three waves, the alpha wave peaked at about 150 cases in one 7-day period. The delta wave peaked at 536 cases. The Omicron wave that continued into 2022 peaked at 1,935 cases, and it stacked right on top of that Delta wave. This is the same image from everywhere, is that it goes up super fast, comes down super fast. But if you think about sort of that low point leading into July, Delta caused about a 2,000% increase in cases. Omicron caused 350% increase on top of the Delta wave. So if we have a new analogy, it's sort of like Omicron surfed on top of the Delta wave and then just kept riding it up higher. That is the cases. Right now, we're at the lowest 7-day total for the weekend, the 7-day period ending on March 8th that we've been at since before Delta wave. So we've only had 26 reported cases now. We had roughly 25 before the Delta wave. And then the next lowest 7-day period before that was June of 2020. And there were 21 cases in that period. I mention that because I think it's important that we could likely see maybe in the future a biannual increase in cases as opposed to where you see flu increasing in the winter. We may likely see increases in the summer and in the winter again. Any questions or thoughts over these data sources? No? Okay. So what was shared in advance was the CDC community level guidance, where they take a new approach to understanding what's the new cases in a community over the preceding 7-day period, and what's the implication or what is going on in the healthcare system, to then advise sort of what their guidance level is at, low, medium, or high, and it's driven primarily by the impact of the new cases and the occupation of beds in a hospital, or the new admissions, whichever is higher as a percentage of the staffed beds or the admissions per capita. On this, you see that when your community has had fewer than 200 cases over a 7-day total per 100,000 people, that there is always the option to be in the low level. When that goes above 200 cases, you're automatically in the medium level, regardless of the impact on the local healthcare system. And that the justification from the CDC on that is anticipating the potential impact of those increasing cases on the healthcare system. So it's really a move from this pandemic emergency phase to realign the guidance. It delineates it, individual behavior guidance, community prevention guidance and recommendations that you would make out from a community level, to really reflect that we're in this endemic state and will be for probably in perpetuity on COVID-19 being around.
Is this, Josh, is this being adopted by the State Department of Health as well?
They did recently reflect it earlier this week in their COVID-19 updates. I don't know if they've actually formally adopted it yet. Have they, Monica?
I missed their update this week, but they have been talking about trying to realign it with this. I don't know if they're going to formally adopt this, but they keep pointing everything to it. So, and they're taking a lot of pieces off of their dashboard. So I wouldn't be surprised if they do that, because they're not wanting to maintain a separate dashboard and metrics in perpetuity either. So they've pointed everybody to this guidance multiple times, and they've realigned their dashboard with more of the kind of ongoing metrics and taken off some of the emergency metrics. So
I see.
but they're still doing their color-coded county map for now.
Do you anticipate, and I know it may be hard to know this, but will COVID, and this may be a stupid question, so correct me if I'm wrong, do you believe that they'll adopt COVID-19 as another communicable disease that you will all be responsible for tracking in perpetuity, like just like any of the other list of communicable diseases that you have now that you're responsible for?
Josh may have some guesses. I think for a while it'll continue to be on the reportable condition list, but eventually I would be surprised if it does, if it's anything like flu, because flu isn't a reportable condition, but flu deaths are. Okay. So, and it's something you monitor, right? So it's something you do active surveillance on. So those surveillance tactics are something that they're trying to build up, but not necessarily reporting every case.
Okay. I'm just trying to understand the wind down of this. Like, are we going to continue to, like, data and dashboards and all of that, or does it get to a point where you're kind of no longer doing that, but you guys are surveying, deaths and things of that nature? Yeah,
ideally, and my hope, I guess, for us going forward is we would have some kind of dashboard for these seasonal things, just so that we could kind of pass on, like if the ERs are starting to get hit with flu, we can say, oh, it looks like our flu surveillance system is showing a wind up. Our COVID surveillance system is, whatever that system is. And there's a lot of things in development, including, I know that Carmel did this during the pandemic, but it's been talked about a lot recently, and the CDC has a lot of programs for monitoring wastewater for as a form of surveillance, and that would be really useful. So I've started looking into that. Way more effective than trying to count every individual home test that people do.
So longer term, like in the next 6 months, do you guys envision taking down our dashboard and replacing it with something that's more timely and more broad in our review of communicable diseases? be it flu, be it COVID, what have you?
This surveillance will stay, so those activities will stay. We'll continue to do this surveillance. I definitely think that the mode with which we communicate the impact of COVID will change. So dashboards coming down, it would be a natural transition to wind down the frequency with which it's posted, but to continue some form of education in the short term on what's the current impact of COVID.
Gotcha. Yeah, I assume there's an inward and outward component to this, right? You guys
Yeah.
may very well continue on for an extended period of time in a different manner, but the manpower and the resources and the work that goes into communicating every week where we are with COVID, I don't know when the right time is to transition, but I assume we would transition at some point.
And we've gone up and down on those. I mean, at certain peak times, we were communicating daily.
Yeah.
And then for most of the last year, it's been weekly. And then we've recently taken it back to every 2 weeks,
Yeah,
which, causes, for people that look at it a lot, we
Yeah.
always hear from them when we change that. They're
Sure.
like, how am I going to know? I can't wait 2 whole weeks. But I mean, you're right. There's a lot of manpower that goes into it. Like Josh was saying, it takes a whole separate computer, a whole day to analyze the vaccine data. So,
yeah.
That's just to process it. I then have to export it and analyze it, so yeah.
Okay.
So that's sort of a quick overview of what the metrics are to account for community levels from CDC. And then I believe you've been able to have the opportunity to see this before. The way that they structure their guidance is at the community level for COVID, what are the individual and household behaviors one should consider based particularly on their risk category, so whether they're immunocompromised or have someone within their social network that is of high risk. And then commensurate community level strategies that by and large are a reflection of the transition as an endemic state infectious disease. What are the recommendations that you could tailor based on the context of the impact of COVID to your community outward, with the exception of those recommendations being a bit more, a bit higher priority to reiterate those when you're in a high level, and particularly if you start to see a very high level of strain on the healthcare system. Are there any questions over the rationale or justification CDC? Nope. Okay, I'll move on. So with that, we've provided a tremendous amount of services, which I'm really excited to have it be reflected in the annual report that will be coming out at the end of this month. But with the waning and decrease demand for testing and vaccination services, we are coordinating a move away from our high volume mass vaccination clinic and our 2-lane high volume testing site to centralize all services in Technology Lane, which is just across the street from here where we initially started with those services. Still be able to keep up with current demand, and we have it at a staffing level that would be able to take on surge capacity if needed in the near term. And it will actually allow us to maintain 6 days of operation at hours that will be really good for the public. So the 9 to 1 on Monday, Wednesday, Thursday, Friday evening, weekend day for Saturday, and then later in the day and early evening for Tuesday, Thursday, where individuals can come in and receive the COVID vaccine testing, but also have that wrapped along with our other services that we're able to currently offer in terms of immunizations and then future services as well. So we'll be making that move and potentially going live with that new site early next month, and obviously putting out all the communication to redirect individuals there. And we'll also be able to offer, through a partnership that we've been using with Aspire Health, where we've already disseminated about 5,000 at-home tests to high-need individuals in this community, for individuals to pick up at-home tests at the new Technology Lane service as well. Okay, so very quick annual report 2021 at a glance. I'm really excited about this. I'm not just a numbers guy, or I am a geek for sure, but I'm just really excited about this because what has been most invigorating to me is sort of the context in which this health department was created and the level it was created at and how it's interdispersed in terms of working across all of city government. So in 2021 alone, our COVID testing site was the highest volume local health department testing site in the entire state, offering that number up there, 55,582 tests. So providing that near immediate vital service to identify, are you infected? You've been exposed, do you have it? And I was really excited to see that we're able to offer that high volume through a tiny 2-lane garage. Other health departments obviously have done a lot as well, and this isn't to say, oh, well, we're the best, but it's just really nice to reflect and see that we did 55,000 COVID tests. Part of that, the majority of those were operated through testing that was started for our residents in the very beginning to give them testing before there was even an option, and continued throughout. And then 43% of those tests were through collaboration to allow anybody that isn't a resident to come through our testing site. Vaccinations, we offered 85,000 in 2021. The majority of those were to residents, but we took a lot of concerted effort to make sure that those that weren't able to come to us, whether it's due to physical or time constraints, whatever constraint they had on them, how can we go out and get them to them? So we delivered vaccinations to homebound residents. We coordinated with the long-term care facilities. We identified lower pockets of uptake in the community and held pop-up events to deliver just under 3,000 out in the community vaccinations in 2021. And from a local health department perspective, this was the second highest volume COVID vaccination effort in the states, behind Marion County. Our contact tracing team did a phenomenal job of notifying over 50,000 close contacts after they did all the individual case investigations from each of our positive cases. They completed every one of those 50,000 calls and notifications in under 24 hours. And that's no short feat with just a staff of 15 contracted workers, but it's often difficult to understand the importance of contact tracing, and you can't do a randomized trial where you notify some people that have been exposed and haven't, but as serendipity had it, there's a really good natural experiment that happened in the UK through failure to properly notify people. They give some good natural experiment evidence showing that fast, expedient, and comprehensive contact tracing can decrease secondary transmission by up to 63%, which could potentially decrease deaths from secondary transmission by 66%. So it'll be hard to always put a good number on what 50,000 calls meant, but it definitely meant something very important. We also launched our immunization clinic, initially starting off at just 1/2 a day a week in June throughout the end of the year, and then occasional additional services, and reached 63 individuals that way. Had a plethora of health education events to connect to the community. And I have just some quick numbers on our health inspections, permits, and vital records. And the two graphs on the right are, the top one is the testing by testing type. So the blue bars are resident-only tests. The orange bars stacked on top are the all Hoosier tests that residents and non-residents could receive. And then the gray bar shows you the volume of rapid tests that we did. And then down below it is vaccinations administered by calendar week. Any questions? No? Well, one other thing that I did calculate before I came in that I'm excited to talk about, but it'll go into our after-action review on COVID, is it sort of thinking about what have all the services meant, particularly to not only the community, but given the high mobility and the population density here, how do we get a good measure on what we've done has had an impact? And a crude but good measure is looking at the observed case fatality rate. And that's where you look at the number of fatalities from COVID based on the number of cases you saw. In the US, that was 1.2%, Indiana was 1.38%, Hamilton County was 1.11%, and Fishers was 0.603%. Yeah.
So are you wanting to say that we're the best?
No, everybody did everything that they could, but
We just did it better?
It is amazing the things that you can do when you can mobilize an entire city government behind
I do-
something and
Well, so-
have the freedom or the ability to move very nimbly since you're so new.
Not to discount all the great work that was done, because it is incredible and the outcome's wonderful, but in terms of the after-action report, I do think there's something to be said about, and I know, Chief, we do this with our emergency management stuff, but, you know, what infrastructure, what lessons learned, what things should we be considering and keeping in preparation for, hopefully, no day that ever comes like we've had, but I just think we'd be a fool to say, well, we took care of that, now let's put that in the rearview mirror and never think about it again. And I don't really know what the right balance of that is. I'm not sure that anyone does, about what capacity or capability do you keep within your ranks? What resources do you keep within your ranks that you can scale up quickly? The good news is we have some institutional knowledge now through the School of Hard Knocks, but that also atrophies over a period of time where people move on and then all of a sudden no one remembers what it was like when you had to do that. So I'm just curious what formal process we would go through to really think through that moving forward.
So the State Department of Health has already started their after-action review, and we've participated in that. Our nurse, Emily, is funded partially by the Public Health Emergency Preparedness Grant funding from the state, and it's a requirement anyway.
Okay.
Not that we wouldn't do it also, but it's a requirement that we complete it anyway. And the D5 Healthcare Coalition even provided some funding to help support completing that after-action review with help of a contractor. So yes, we absolutely will be doing this. And I don't remember what the timeline is for the requirements, but.
Yeah. Because I think it'd be interesting even from a policy perspective, because of the way that we approach dealing with it and drawing on a lot of different resources within our organization. You know, is there ongoing annual training or awareness of other departments that would put them in a position that if something were to happen, you know, you can tap into the fire department because they now have a fundamental understanding of certain public health concepts, you know, or the police department or whoever. I just think thinking through those policy decisions and what we need to do to be ready going forward would be important.
Yeah, I agree. I mean, just our reflex time, we could reduce drastically. But the was it fatality data that you quoted?
Observed case fatality, so it's.
Yeah, I think there's a story there. I don't know what the format of that story looks like, a report to the community on COVID-19, whether it's at council or just on the website. But I think the numbers that you quoted are remarkable, especially considering that we built this thing during a pandemic and the outcomes that we have. And I think there's valuable things that other communities can grab out of that story, and it's upon us to share them. So I think that's something that we should think about.
Yeah, I agree. It's 100% incumbent that we approach an after-action review thoroughly, comprehensively, and very systematically, because there's a lot to learn from what was able to be accomplished. I don't think there's a single city department that didn't contribute in some very meaningful way. The support of council, residents have been phenomenal, and it is not. It is something that we will do and do right and do well, and we'll need to also get some external support to do it as objectively as possible. I was really wanting to be able to come to this meeting since it's been 3 months and be like, okay, here is our draft conceptual framework and our data analysis approach that we're going to take to do this. But that stinking Omicron surfer came in and really knocked us back for a little bit there in the last 60 days.
Yeah, well, I mean, I think the sooner the better before people forget aspects of it. And I also don't think it's a victory lap. I mean, I think we did amazing things, but there were, you know, being witness to it here within our own organization, there were stress points or, you know, fractures here or there where we could get better and make sure that we can do better, respond quicker to whatever variety of things come forward. So, you know, I don't know if that's a third party evaluation or after action facilitated. I don't know how you guys are thinking about this process, but, you know, it spans 2 years in every department in this organization. That's a heavy lift if you really want to deep dive into it. And then the other part that's complicated is your kind of interdependence on state and federal involvement too. So how you want to approach it, I don't know, but I think it would be important to do.
Alrighty, I'll pass it over to Monica. Thank you.
Thank you, Josh.
Well, he moved ahead, but actually we did have kind of a question, and a reason for presenting the CDC metrics was we were proposing that we take down the community metrics that we built like 2 years ago, or a year and a half ago, and that we just point to the CDC metrics. I think the mayor has brought up that the state has a different set of metrics and they haven't totally gone to that yet. So we're kind of wanting the board's thoughts on this and recommendations for what your preference would be.
Thoughts?
The CDC has gotten some criticism for these metrics because they are so much looser from a numbers perspective than they used to be. So a lot of counties found that they went from red to green overnight when they updated these metrics. But the reason for that is because you can take on a much higher level of disease burden with vaccinations, and it really transfers that worry zone over to hospital capacity, right? So it's really the overwhelming of the hospital systems that is the biggest factor in where you're at. I think I would be more worried if I was in charge of the whole state of Indiana, because our vaccination rates are not good. But given that we have very high vaccination rates here in Fishers, I feel very comfortable with these metrics, and saying that it's, you know, absorbing 200 people per 100,000, 200 cases per 100,000 in a week. It sounds like a lot. It's a huge leap from our current metrics, but we're in a completely different place in the pandemic than we were, and we have very high vaccination rates. And I've never, quite honestly, I've never been a fan of the state's metrics, so I would rather not point to theirs.
Do we need a motion on something like this?
I would think if you're asking for our direction, if you get
Yes.
consensus. So I'd entertain a motion to replace our metrics with the current CDC metrics, and I assume ongoing, if they were to update them, it would automatically, we would just be referencing whatever their current state of these are.
Assuming there's nothing super weird that happens, that we would bring you back together
Yeah.
to
Okay.
ask for different guidance, yeah.
So is there a motion? There's a motion. Is there a second? Second. All those in favor, please say aye. Aye. Motion carries.
Okay, that was easy. Thank you. All right, so I'll go back just to updates on where we're at so far in 2022. So on our population health activities that we're doing, we have expanded our immunization clinic services. We've been doing a second half day per week. That's pretty recent, just in December. And then we are really looking to kind of hit harder on the immunization for, you know, all the immunizations, not just COVID immunization. A lot of the data is showing that the kids have fallen way, way, way behind on required immunization. So that's a push that we're making. So we're hoping to, over the next couple months, roll that into those 4 hour per day open times for the clinic, so that anybody could come into the clinic for any service, ideally anytime we're open, so that we're not kind of separating testing and COVID vaccines and other vaccines. It's just all-in-one. The other population health stuff that we found recently, we've had an increase in latent TB over the second half of 2021. That seems to be continuing now. I don't have a solid reason for that, other than people are getting back into the providers, so providers are starting to count them. We don't have a long term of data to know what the usual is in Fishers. We started in the middle of a pandemic, so people weren't going to doctors, and now we're seeing an increase. It's still not a high rate, and we still haven't had, let me knock on something, any active cases of TB, so this is not infectious TB. We're also busy working on an event calendar and other activities to do with various partners to build kind of a culture of health, looking at kind of co-sponsored activities, things that that Parks is doing that really has a health tie-in, and kind of, you know, ramping that up, or things that we're doing that that has a Parks tie-in or that has some other organization. So we've been really working on partnership building and kind of cross application of services going forward. Example of that is we have upcoming, we're starting a series called Let's Walk About Health. And we're going to be taking a walk in one of our parks to highlight our park, but we'll have an expert, and the first one will be Dr. Lane. And our first event is the 20th. Is it the 20th? The 20th at Flat Fork. This isn't just an advertisement. I'm trying to tell you the concept. But please do come. Bring your families. Bring your strollers. Dr. Lane will be going over, you know, various screenings that would be appropriate for women. This is Women's History Month. So, you know, perhaps a person of my age might want to know, what should I be doing every year? Do I need to be getting any kinds of screenings every year? So she'll have a short talk about that, 5-10 minutes tops, and then just a walk and talk. And anyone can just ask questions or, you know, bring up general concerns or questions about the health department or about that particular health topic, and we're inviting other experts to join in this too. So I would open that invitation to all of you, but we're also working with Community Health Network as well, and they're, I think, excited about this opportunity too. So. Our mental health initiative, we continue to move forward with those goals. We're still meeting with the core team. We started a caregiver support group. We've had 2 support group meetings so far, and there seems to continue to be a fair amount of interest in those. As more people hear about them, we get different people finding out that there's an interest, so this definitely seems to be a need. This was something that grew out of the first phase of our community health assessment that we did. We held a number of focus groups, and this was something that people asked for, so we started offering it. We also have been offering a series of QPR, which is kind of like mental health first aid, but a brief one. It's a suicide intervention, very brief screening process that you can go through a training for. So our health educator is trained as a trainer. So we've been offering those to the community and different community organizations, as well as youth mental health first aid training, which is a much longer process than QPR. It's an 8-hour training. So we've started offering those throughout the communities and with different community organizations. So people can sign up for those as well. We're also working on planning some activities for Mental Health Month, which is in May, including the Hope for Happiness event in conjunction with the Parks Department and the PR and the HSE schools. So continuing to work on a number of partnerships there. We're not trying to create services that exist somewhere else. So as we are kind of gathering the resources that other organizations have, we'll be able to more efficiently point people towards those resources and not have to create them ourselves. I'm hoping that I can use some of the grant funding that I'll talk about in a minute to fund possibly a social worker. That was a number one ask from some of the folks in our focus groups, and also from the schools, actually, that they have their own social workers, but they can't take care of families, so they were looking for a way to have help with triaging families. So this was something that a number of partners and citizens were thinking would be really helpful to move our mental health initiative forward. Environmental health, these are our 3 main inspectors. They attended a conference last fall, so they're all dressed up. It's kind of nice. They've been updating themselves on a number of trainings, most recently vector control and radon trainings. Our health inspectors for the food establishments won a small grant from the FDA to conduct assessments on our process to standardize it with the FDA's process. So that's all part of lining up our food code. Our goal is that we will make the food code or make our inspection process into a letter grade system. Right now it's a pass-fail. So we're working towards that, hopefully having that ready by the end of June. And then, possibly council may want to take action on what the implications of different letter grades may mean or not.
This may be a Chris question, but is that this board would adopt those grades, or does that get adopted into some sort of ordinance schedule, or what
It
is
probably will, yep. So I think what we would do is we'd probably bring them back here for an initial recommendation and then adopt them with the enforcement mechanism as a formal ordinance. Well, as we get closer to that, we can go through those details.
Yeah, we're not quite there yet, but the goal is that it's a little more differentiated than just pass-fail.
Sure.
And then you can pass ordinances on top of how we do the inspections or how we rate the inspections, whether it's a number or a letter grade. But a lot of communities have chosen to, for example, require restaurants to post the letter grade on their door or something like that. Now, whether Fisher's chose to do that or not, we would at least be ready from a structure of the inspection process standpoint and make sure that it's in line with the FDA. We're one of only 5 health departments that are part of this FDA program in the state. So we're pretty excited about it. And the focus is very heavily, not just on so the standard inspection process is very heavy on you did this wrong, you did this wrong, you did this wrong, you fail. Without a lot of education on it. So we've been working since day one to have a heavy education focus so that they know why they're doing these things and so that they're meaningful and actually preventing foodborne illness. And the FDA program supports all of that because the focus is really on preventing foodborne illness, not making a lot of meaningless, nitpicky marks on paper. So we're excited about that program for that reason too. It really helps us have structure to what we were already trying to do. Let's see, ServSafe training. We've started conducting ServSafe training for restaurant operators, and they've been quite popular. We have had one. We have a couple of more in the next month. One of our food inspectors is also trained to do those ServSafe trainings. He's been at the ServSafe training, and it was really valuable because those usually aren't offered with a health inspector. So having the health inspector's input has been really helpful for the restaurant operators, and they gave us that feedback as well. Our food operating permitting, usually those are due January 1. We do still have a couple of operators out there that haven't renewed yet, and so they will be hitting a deadline very soon that we have set to, now's the time or else we have to close you. So hopefully they'll get those in the next week or so, but they've had quite a long time. It was due on January 1st, so. We're also looking at our aquatic code. As you guys know, we built all of this pretty quickly. Our aquatic code is very thorough, but the CDC actually has a model aquatic code. So we're looking at that and how that lines up with our current code and the state's code to see how much more in line we can get those things as well. And then I think I already talked about the letter grade system. Any questions about this?
I do recall a late night email string with our esteemed legal counsel discussing the intricacies of the water code in those early days of the pandemic. So I'm glad to see other more capable hands have taken it much further than we started it.
So one of the interesting things about our water code is that we're one of the few places that requires a certified pool operator permit in order to operate a pool. So we were pretty lenient last year with everyone and talked to all the pool operators pretty extensively about how to obtain that permit. And this year we're really going to work towards making sure that everyone has it. But it's been a process, so we've been trying to give everybody enough time to adjust without just putting the hammer down. I'm not sure why I put this here, so I'm sorry if this seems disjointed, but phase 1, report on our community health assessment. So this is one of our mental health consultants, Suzanne Clifford, helping us conduct one of the focus groups that we had. So we held 10 focus groups with representing 68 different participants, and they represented a lot of different organizations in the community, as well as different interest groups. We got a lot of really valuable, interesting perspectives. So this is really for the qualitative portion of community health assessment to really kind of give us the context and where people are at, and we asked a lot of open-ended questions primarily. The next phase is to do a detailed data analysis of all the secondary data sources, and then we'll have a broader community survey for the full assessment. What we've identified through the 10 focus groups, and we also distributed those same open-ended questions, there were just 5 of them, on some surveys at the vaccination site, and tabulated that data as well. We got 208 of those surveys back. They all seem to coalesce and say the same thing. Mental health is a top priority. Substance abuse and alcohol abuse were a top priority. Social connectedness, health education, and COVID-19 were all identified as top priorities. So I'm not surprised about COVID. It was, most of this was done in last quarter of 2021. And we have a draft of that report that's, I think, in the final stages with PR. That what I'm hoping is that we'll be able to then send this out to the people that participated in the focus groups, so they have, they can see what the data showed, how their input fit into that. They all really wanted feedback. That was something that was said to us a lot. And what actions we were taking as a result of it. So that was another ask. So we have an action plan with that. So when we get that finalized, I'll send that to all of you all as well. And Josh already mentioned that we're finishing up our annual report, which is due to the public as part of the requirements of the health department and health board. So that again is also with PR to make it look a little bit prettier. And when we have that draft ready, then I will send it to you all for feedback before we publish it, so that you'll have an opportunity to give some input on it. But what Josh presented earlier was the core data points that are in there. These are where we're at on inspections so far, and vital records this year. We usually give this type of information, so a lot has already happened. And communicable diseases. COVID-19 is still leading. Chlamydia is still number 2. Everything else is less than 5 for the most part. So that's where we're at on those. I did just want to go over with you, as the mayor mentioned, we are pretty heavily dependent on the state, not just for COVID-19 activities, but also just for basic funding of the health department. So I just wanted to give you a little sense of where this comes from. So primarily, health departments in Indiana are funded by property taxes. So that's the percentage that we take in Fishers of property tax to fund the health department. Most of the COVID activities have been submitted for reimbursement to FEMA. So that's how the vast majority of that has been paid for. Although I do not think we've actually received any funding yet from FEMA. It's been theoretically approved. The vast majority of it has been approved, but not yet received that money back. So
Early, I think 6.4 million. Is that?
It's a lot of millions.
Yeah.
Yes.
Is it? Yeah.
And frankly, we're fortunate to be in the position where we can even do that because the city has a rainy day fund. Otherwise, this is not something that any city could do without that. All of those letters together is basically a local health maintenance fund money, and a lot of that comes from tobacco tax, and it goes to every local health department. It's just distributed by the state health department. So that money and the FEP grant, which is Emergency Preparedness Grant, those together support our public health, one of our public health nurses. And some small amounts of emergency preparedness related supplies. We also received some money to provide the COVID testing, to support staffing and supplies, as well as some money to support COVID vaccines in addition to our regular childhood vaccine program. We had applied for a grant from the CDC to support a public health associate for mental health coordination, and we received that grant. So that associate started in October, and we have her for 2 years. So basically the CDC hires her and pays her, but she is stationed here for 2 years. And then the last grant that came through is what the state's calling the COAG grant, and unfortunately I can't remember what on earth that stands for. But it is a combination of, I think, money that came to the State Department of Health and money that came to schools in order to support COVID activities. Unfortunately, it took quite a long time to roll out, and we haven't yet received the money for the first grant period, which was July of 2021 through June of 2022. That requires us to designate a school health liaison in order to coordinate things with the schools, and has all of the deliverables are based on really kind of improving public health in schools and supporting schools. At the time it initially came out, it was focused on helping the schools get COVID cases reported. Since COVID reporting requirements have changed, it's really transitioned into kind of an all public health, immunization, promotion, health education, promotion, coordination of communicable disease outbreaks in schools, kind of a process. That grant is temporary, it's for COVID funding, and that we're expected to get $330,000 for each year of 2 years, and then that's gone. So those are the funding sources in brief. Do you have any questions about that?
330,000 a year
A year, yeah.
to hire school social workers?
To hire, so what they've told us, and this has changed several times, so I wish I could be more clear, but unfortunately, the state has changed the deliverables since the first time that we received the grant contract, but it's $330,000. It's a deliverables-based grant, so all the deliverables are focused on naming your school liaison, conducting an assessment of the schools, stuff like that. As long as we're doing those activities, they have told us that we can use the funds to support other activities that support those things. So they have told us that that would be appropriate for mental health. So I can get that permission, and so that, again, when I asked the schools, when we first got this funding, my first ask was to the schools. What do you guys need? How can I support you? And that's the only thing that I got back was, we could really use your help with social work, because ours can support the kids, but not the families, and the families really need someone to help them navigate the system.
And does the money have to be spent in 2 years, or can it be prolonged?
I'm not totally clear on that because the benchmarks keep changing, but it has to be invoiced. The first year's worth has to be invoiced, I think, by August of this year, and then probably the second year will have the same stipulation, but you have to meet the deliverables in order to invoice.
Okay.
So the invoicing is based on which deliverables you've met.
I see. Okay.
Yeah. So I have weekly meetings with our grants coordinator.
Yeah, I bet.
That's all I got. Any questions? That was a lot. I haven't seen you in a long time.
Doing a lot, which is fantastic. It's amazing what you guys have done. I have a couple questions on turnover of the board. One, Chief, you mentioned the other day to me that EMS runs were up 22% overall last year, and then so far to date this year, you said they're up 30% over last year's 20% increase. Josh, there seems to be this missing middle where you have emergent issues where the guys on the street, the men and women on the street, see issues, and then you have like your community health needs assessment where it's very high level and it looks back over multiple years. Where do we bridge the gap to be nimble, so when we start to see these things happening, we can adjust public policy sooner and work with public health to actually maybe prevent that prior to like a look back every 3 to 5 years? So are you guys taking EMS data and using that, or is it too close to the action, so to speak, like it'll whipsaw you guys back and forth if you try to go off of that? You know what I mean? Like, would it be inappropriate for you guys to say, oh, it went up 30% in the first 3 months, let's go run out and do something? You know what I mean?
The nice part about the fire EMS data is its longevity. So they've been using one system, one EHR, since early 2013. There are very good data collection fields in there to look at the cause for the run, the reason for the acute EMS supports. And then there is also a way for you to interrogate the unstructured narrative text. The only downside to that is it's a partial picture of, for example, the acute mental health needs in the community, whether it is somebody who is a bit combative based off of some issue rights, but they have an underlying mental health condition. It gives us a partial picture because it shows us the acute need that's going on that may reflect an underlying chronic issue for this individual, but across other individuals. We do look at it on a monthly look-back basis. I help our now mental health coordinator look not only just at the overall increase, it's primarily just on the mental health runs, but also at the case rates across different demographic characteristics. And we've been really fortunate recently to have Chief Davison help lead an initiative to potentially collaborate with police to get another side of the type of underlying data sources that we have here to look at acute mental health issues in the community.
And those acute mental health have been things that we've focused on for a while, but like Chief and I were talking about the other day. I mean, this unbelievable tsunami of elderly people, we just did a housing study in Fishers, and the demand for senior housing is just skyrocketing, both from a skilled care all the way back to independent living. But it's incredible the growth that we're about to see, and I think we're seeing this in the, anecdotally anyways, I can't confirm this in the numbers because I don't know, but anecdotally in the runs that we're taking for emergent cases seem to be primarily of people in their older ages, and I don't know if that means we need to start contemplating from a public policy perspective and from public health, how do we swim upstream and make sure these people are getting the services they need to keep them out of the back of his ambulance. By the nature, you're gonna have more runs just by the elderly, but what types of those calls are we going on? Is there a direct correlation to age? All those things I think are something we should look at.
It's a wonderful data source to feed into our surveillance activities. We also get access to a statewide database that allows us to look at cause and reason and a host of demographic characteristics for ER presentations on just our residents. And so ideally, combining fire data, police data, ER presentations, we can get a greater sense of the acute health needs and issues that are going on.
I think that might be something interesting to incorporate into these conversations moving forward. I mean, I think the chart that shows communicable diseases is always helpful to see what you guys are following up on. Mm-hmm. But on your surveillance report or the conversation with this group as we start to plot our course forward, talking through where we see emerging trends and general public health issues might be helpful.
Having the fire data is really, it's great, right? It's a great source of data. I think where you have to be careful is if you're looking at like a respiratory illness and you're seeing a spike in respiratory illness, like a shortness of breath complaints for ambulance runs, that's the kind of thing where we can say, okay, we probably maybe need to be nimble because there's some kind of respiratory condition going around, and we need to try to think of what to do about that quickly. Versus if the data are showing that 99% of this is falls, right? Then probably not everybody's falling down from a virus. They're probably falling down because of poor nursing home care or something like that, and it requires a completely different approach and a longer term approach.
Yeah, no, I agree. I mean, and I think what will be interesting is you guys working with Fire and EMS to craft the data in a way that actually makes a value add on the backside. Mm-hmm. And I know that's an ongoing discussion.
Yeah, I think there's a ton of opportunities there, and I've been excited kind of about that since day one, but I've been a little distracted by other things.
Right.
The fire has just really done Chief Arusa and his team have done such a fantastic job of having an EHR in place for so long, and now, for example, Chief Davison that works with Chief Arusa has taken a really concerted action to get connection to the Indiana Health Information Exchange, so we'll no longer be limited by what is the reason that we presented with EMS support, but we'll be able to see the disposition for each patient after they hit the healthcare system to understand. We took them there for an acute substance overdose, right? but what was their cause for their length of stay, and what other characteristics can we look at to better interrogate to understand a fuller picture?
And then,
And
and then tacking onto that is Gelada, that they've been rolling out countywide to help coordinate the services, and that's going to be a slow process, but the dream is quite big, that then the people that want to do follow-up can see where somebody's been through the system, and it's all a little bit easier to follow instead of just telling someone, hey, go get some handrails installed so you don't fall again, and this organization does that. Good luck. That each organization is able to track where things are in the process, so that'll be helpful too. Sorry, Josh, I think I cut you off. What were you saying?
No, I just, as a nerd, am excited about when you have this type of underlying data structure.
You've professed to be a nerd several times today.
Yes. But it takes you from sort of like a hypothesis testing scenario where you want to answer a question to, now that you have so many connected data sources, it's a hypothesis generating scenario. How can we ask better questions of this data to inform our approach to policy, services, programs?
Excellent. I thought the very same thing, Josh. What he said, yeah. Are there any other general questions for Monica or the team? Dr. Lane, anything you want to add?
No, I think Josh summed it up. Although that data, just from a hospital perspective, I'm curious how much of it's related to delayed care. The hospital systems have had to stop and start, and there's been a lot of fear. And we're seeing the results of that. A lot of people who haven't either sought out care or did not come to the hospital or weren't able to come to physically see their doctor. So some of that may be related to chronic conditions that haven't been maintained. But no, I am just so happy to be associated with such a fantastic team and just outstanding work.
Excellent. It would be great to figure out where and how to tell this story, because it's pretty unique. I'm just not sure where that venue is. But Monica, if there's nothing else, it's Friday at 4 o'clock. And I'm sure you guys have some other places you'd like to be. So I will entertain a motion to adjourn.
Motion.